Good morning, everyone. I'll be taking the topic maxillary anatomical landmarks. So, if we see the contents, I'll be talking about the maxillary arts, the histology, supporting areas, peripheral or the limiting areas. So, according to given, the aim of the prosthodontics is not only to the meticulous replacement of what is missing, but also the perpetual preservation of what is present. So, a processes must function in harmony with the tissues that supports them and those that surrounds them. Hence, the dentist must understand the macroscopic as well as the microscopic anatomy of the supporting and the limiting structures of the denture. So, this knowledge aids in determining the selective placement of the forces by the denture basis upon the supporting tissues and the form of the denture borders that will be harmonious with the normal function of the limiting structures that surrounds them. The intraoral landmarks. We see the intraoral landmarks of the maxilla. Basically, it is classified as the supporting structures, limiting structures, relief areas, and the stress-bearing areas. So the stress-bearing areas is again classified as your primary stress-bearing area and the secondary stress-bearing areas. According to 9th edition of the brochure and the 12th edition of the Sir Volunteer maxillary arts, that is classified as stress-bearing area and the relief areas. The stress-bearing areas again it is classified as the primary stress-bearing area and the secondary, that is your relief areas will be incisive fibula, median palatal traffic, radial palatine. According to voucher, it is the stress-bearing area is classified as primary review bone tuberosities, hard palate on the other sides of the palatal trapeze. Secondary is the rugae in the alveolar ridge. Relief areas will be palatal torus, median palatal trapeze, and the fovea palatine. The primary stress-bearing area, those are the areas which are able to resist the vertical forces of occlusion. So in maxilla, mainly it is the bone tuberosities and the slopes of the hard palate on the either sides of the palatal trapeze. Secondary stress-bearing areas are those that resist the lateral forces of occlusion and that can aid in the resistance to the vertical forces. So in maxilla, it will be the alveolar ridge and rugae areas. We see the relief areas. These are the portions of the denture which is relieved to eliminate the excessive pressure on the specific parts of the denture supporting tissues. The relief areas will be the incisive papilla, mid-palatine trapeze, torus palatinus, sharp bony prominence, and the fovea palatine. Next is the supporting areas. So if we see the supporting areas, we have the alveolar ridge, hard palate, incisive papilla, palatal rugae, median traffic, maxillary tuberosity, fovea palatine. Next is the peripheral or the limiting areas. We have labial frenum, labial sulcus, buccal frenum, buccal sulcus, distobuccal space, alveolar notch, the posterior palatal sleeve area. Here you can see the labial vestibule, labial frenum, incisive papilla, labial sulcus, palatine traffic, residual sulcus, tuberosity, alveolar notch, palatine fovea, soft palate, vibrating line, alveolar braces, hard palate, buccal vestibule, buccal frenum, residual ridge. So this is basically the correlation of the anatomical elements. So in the landmarks in the mouth, that is different from the landmarks of the impression. We state the landmarks of the mouth, that is the labial frenum as labial frenum, that's in mouth, and in impression we will tell us the labial notch. Same like that, we have for labial vestibule, it is labial flange. Buccal frenum, it is buccal notch. Buccal vestibule, it is buccal flange. Coronoid bulge, it is coronoid contour. Residual alveolar groove, maxillary tuberosity, it is maxillary tuberosity. Alveolar notch, maxillary seal, posterior palatine seal, posterior palatine seal, fovea palatine, middle palatine, mid palatine groove, incisive papilla, incisive force. Rugae ridge, rugae, displaceable and soft and hard palate, butterfly outline of TPS. We see the mucous membrane. So your mucous membrane is divided as the mucosa on the submucous. So mucosa, it is formed by the stratified squamous epithelium and a subsequent narrow layer of the connective tissues present part as the lamina propria. And for the submucosa, it is composed of the connective tissue that varies from the dense to alveolar, loose alveolar tissues. So in edentulous patients, the mucosa covering the hard palate and the rest of the residual ridge plus your residual attached mucosa that is called as the masticatory mucosa. And in case of submucosa, the thickness varies and may contain glandular fat or the muscles and transmit the blood supply and supply to the mucosa. And your mucosa that is characterized by well-defined keratinoid layer of the outermost surfaces. And for the submucosa, attachment occurs between the submucosa and the periosteal covering of the bone, and it makes the bulk of the mucous membrane. So these are the layers of the mucous membrane: lamina propria, papilla, fascicular, and submucosa. Next one, that is the alveolar ridge or the residual ridge. So this residual ridge, it is the remnant of the alveolar process which originally contained sockets for the natural teeth. So after the natural teeth are extracted, these alveolar ridges can be expected to get smaller. That will get resolved. Your maxillary resorption and the mandibular resorption patterns will be different. The rate of resorption will vary considerably from the person to person. This is your residual alveolar ridge. So moving to the histology of the mucous membrane covering the crust of the submucosal layer that is sufficiently thick to provide the resiliency for the support for the complete tension. So that basically for that, the crust is called as the primary stress bearing area. Next is the hard palate that is made up of the anterior two-third of the palatal wall supported by a bone that is your palatine process of the maxilla and the horizontal plates of the palatine bone. These palatine processes are joined together in the medial sutures. If we see the configuration of the hard palate, these hard palate are classified by the various orders according to calls its tapering, square, or the arch or the flat. According to Hartwell, it is based on different slopes. We have V, U, or the median, flat or high. So next is the incisive papilla. So it's a pad of fibrous connective tissue overlying the orifice of the nasopalatine canal. The basic significance of this incisive papilla is the stable landmarks and gives the relation to the incisive foramen through which the neurovascular bundle emerges and lies in the surface of the body. Basically, it is the biometric guide which will give you the information of the positional relation to the central incisors, which is about the 8 to 10 mm anterior to the incisive papilla. And if you draw a line from the canine to papillary line, it also give a positional relation plays the canine. Next is the clinical consideration. During the final impression procedures, care should be taken not to compress the papilla. Hence, if the incisive papilla should be relieved with the spacer. Why we should relieve with the spacer is that if we, what will happen if we didn't apply the spacer over there, that will result in the compression of the blood vessels, which will result in obliteration of the lumen. Then those areas will be deprived of the nutrition to the tissue, which will be finally leads to the breakdown of the tissues. And this pressure on the nerves that causes the paresthesia in the region of upper lip. These are the two reasons which we should give the relief to the incisive papilla. Here you can see the incisive papilla. Next one, that is the palatal bone. These are the raised areas of the dense connective tissue radiating from the median suture in the anterior one-third of the palate. The secondary stress for the median. The significance are said to be the concern with the kinetics, increase the surface area of foundation, and thus supplement the values of retention. It is a danger stabilizing area of the maxillary foundation. Next is the mid-palatine feature. This is the area that is extending from the incisive papilla to the distal end of the mid-palate. The significance are the area of the structural joint and covered with value adhered to the mucous membrane to the underlying bone with the little submucosal tissue. These structural joints that is formed by the median fusion of the two natural process and two horizontal parts of the palatal. The clinical considerations will be during the final impression procedure. This wrapper is relieved in order to create an equilibrium between the resilient and non-resilient tissues. So here you can about the palatine. Next one is the hamular notch. Your hamular notch that is a narrow cleft of the nose areolar tissue, which is approximately 2 mm extending anteroposteriorly. It is situated between the distal end surface of the tuberosity and the hamulus of the medial cerebral place, located by using the tuberculation. The clinical significance will be constitute the lateral boundary of the posterior parietal area in maxillary formation, the pterygomandibular nerve that attaches to the hamulus. The clinical considerations will be the dentures should not extend beyond these hammular nodes. Finally, we use the failure. First one, that is restricted mandibular rubber movement. Second, that when the mouth is wide open, the denture will get dislodged. Next is the maxillary. In the distal part of the residual area, present the hard tissue layers. These are the primary stress bearing area. The basic significance of the last posterior root should not be placed on tuberosity. To see the clinical significance, often there is a lateral and the vertical growth of the tuberosity, and the area is once important when the maxillary antrum extends laterally with the undercut of the tuberosity region. It is important to prevent the oroantral fistula, so it is important to have a regular resection. Tuberosity can be used for the retention of the dentures. Next is the fibula parietal. These are the remnants of the depths of the coalescence, usually two members on either sides of the midline, indicate the vicinity of the posterior parietal area. The dentures can be extended to the So in patients with the thick saliva, this fibula parietal is left uncovered, or else the thick saliva flows between the tissues and increases the posterior pressure and hence lead to the denture displacement. Next is the peripheral of the limiting structures. All those peripheral limiting structures will continue in the next presentation. Thank you.